I request Dr. Valimbe Prasad to start.
Can I have my slides, please? At the outset, let me thank the organizers. Well, the topic is, can brain brakes be lifted? It's a treatment of adult amblyopia. It's a pilot study. I don't have any financial interest in this software. Well, this cloud-based dioptic therapy software called Binox, it's basically designed for binocular vision assessment as well as therapy, and it employs simultaneous and separate stimulation of both eyes using anaglyph goggles. It has got both diagnostic and therapeutic modules, of which I have used the therapeutic module of amblyopia computer-based games. So the purpose of this study was to evaluate the effect of dioptic amblyopia treatment on best corrected visual acuity and stereopsis of adult amblyopic patients who were aged more than 18 years. It was a non-randomized, interventional and prospective study. It's difficult to get adult amblyops, so somehow I could manage to get 13 adult amblyopic subjects with either anisometropic or isometropic amblyopia with refractive error, and the age group of 18 to 52 years with the mean of 26.11 years. Inclusion criteria: all were diagnosed cases of either anisometropic or isometropic amblyopia with associated refractive error and stable vision. They may or may not have been treated in childhood, and they were willing to participate in study with the informed consent. Exclusion criteria: any associated ocular or retinal pathology like say cataract, glaucoma, maculopathy were excluded. Just to avoid confounding factors, systemic diseases like diabetes and uncontrolled hypertension were excluded. Strabismus and also hysterophenia ocular surgery, they were also excluded. All underwent complete ophthalmic evaluation, although they were adults, but I did, at least for the first visit, cycloplegic refraction because most of them had hypermetropic error. Best corrected visual acuity with Logmar and Snellen equivalent, and BSU was checked using TNO. Post treatment, the same set of evaluation was done, and the follow-up was done at 1, 3 and 6 months. Since this is a cloud-based software, any desktop or a laptop with a LED screen of minimum 11-inch with Google Chrome browser and either Google Meet or Teams or Zoom installed in it. Of course, you need to have good internet connectivity with minimum of 512 kbps speed. In the therapy session, both therapists as well as patient connected remotely through either Zoom or Teams or Meet. Patient used either red, blue or red sign anaglyph glasses. One-time calibration of computer for size and color was done using anaglyph. 30 sessions were given of dioptic therapy, and the duration of the session was 30 minutes per day. Post-therapy improvement was seen in vision as well as stereopsis. So of this total 13 patients, 7 were males and 6 were females, and the range was between 18 to 52 years. Interestingly, post-therapy improvement was seen in distance best corrected visual acuity, which was statistically significant using Wilcoxon sign rank test, and improvement in stereopsis was also statistically significant using McNemar test. So this is a cloud-based, I'll just take 30 seconds more. This is a cloud-based program, and most of them were parents of the amblyopic children because they suggested me, my children has improved, can we try this? So that's how I landed up doing this study. So of course there are limitations. What are the long-term results? More than 6 months, they are yet to emerge. And efficacy as a primary treatment, we don't know. And obviously it requires long-term studies and large sample size to prove its effectiveness. So to conclude, best corrected distance visual acuity and stereopsis of anisometropic and isometropic adult amblyopic subjects improved after dioptic amblyopia therapy, and it was maintained through 6 months of period, and it requires long-term studies with large sample size to prove its usefulness as adult amblyopia treatment option. Thank you for kind attention. Any questions if?
Yeah, have you compared the patients who have undergone any sort of treatment before starting Binax?
Most of them had
Between
some treatment
fresh
which
candidates who have not done any treatment, or somebody has done before?
some were treatment naive, some have done treatment.
So have you compared between those two
No,
groups?
because sample size is too small. It was very difficult for me to, because of this exclusion criteria, to get 13 patients. So I appealed to, I'm from Pune, so our Pune Ophthalmic Society, and many of them have referred some of the patients. So that's how I could gather 13 patients, but 13 is a big number.
Okay, and sometimes we see, suppose the children or patients, adult patients who are not underwent any treatment so far, are real good candidates for Binax treatment.
It's sample size is too small.
So were they densely amblyopic or moderate amblyopia? What was the starting vision in this? Like, were the
Around
results?
636.
Most of them?
Most of them, 636. 636, 624. And of course, as what the software, these people claim, you do not get 4 or 5 line improvement, just a line or 2.
Okay.
But which is statistically significant.
And in isometropic amblyopia, how many were ametropic? Because you've included both, so did you
Yeah,
differentiate?
if you, I have this data, maybe because of want of time, if you want, I can share it to you.
And how many of the patients had been doing patching, so first line treatment when you started Binax?
Most of them had done patching, but which was half-hearted.
So did you continue this Binax with the patching, or you just stopped patching and just did only
They were
Binax?
adults. They were not doing patching when I enrolled them. But they had done patching when they were children.
Okay.
Some of them had done patching, some of them have improved.
Okay, so what we do, most of the practitioners do is, like, in case if they are doing patching already, we add as a complementary procedure with patching rather than stopping the patching. And
in fact, I done a study in small children with comparing patching and this thing, but since they were adults and some of them were just only a couple of them were treatment naive. Otherwise, almost all of them had done some patching which was half-hearted or full treatment. Some have improved, some may not have improved.
Good, thank you. And this gives a hope to the adult population, at least something.
I don't know what is going to
something
happen
can be
after 5
tried
years,
rather than
but,
giving them no hope.
And most of them were parents of my the amblyopic children.
Okay.
So that's how they only suggested, can we try? We can try. We can just say what happens to you. We have nothing to lose. Right. Thank you.
I have experience of 3 patients in 13 cases, but I did only, like sir said, only pure full patching,
Yeah.
total patching, but they were highly motivated. That is very important, because patching in adults, it becomes very difficult, but then 3 of them really improved. So without even the additional achievement, pure full.
Yeah, so it will be interesting to see head-to-head trial with the patching and the dichoptic. But I think we need bigger sample size.
How much improvement? Like a line or 2, or better than that? Only by patching? Better than that?
Thank you.
Thank you. Dr. Yogita? I think next presenter, Dr. Nisha, can just be ready with this podium.
A very good evening to all. I am going to present an extremely rare condition, spondylometaphyseal dysplasia, a type of skeletal dysplasia. As we all know, skeletal dysplasias are a group of heterogeneous genetic disorders involving bones, and in which genes related to bone development, differentiation, and mineralizations are involved. There are 3 different types of skeletal dysplasias depending on the type of bones involved, that is rhizomelic, mesomelic, and acromelic. Rhizomelic related to bones involved are the humerus and the femur, and mesomelic tibia and fibula in lower extremity, and radius and ulna in upper extremity. And acromelic related to bones of hand and feet. The diagnosis of skeletal metaplasia is usually done on the basis of radiological investigation, clinical presentation, biochemical investigations, and molecular testing. Spondylometaphyseal dysplasia is a type of skeletal dysplasia which involves metaphyseal ends of long bones and spine. Kozlowski type of spondylometaphyseal dysplasia is the most common type of dysplasia. And it is autosomal dominant type of inheritance, it shows. And it was first described by Kozlowski in 1967, who described it as a rare form of bone disease with short stature, abnormal growth, and skeletal features. It is characterized by metaphyseal irregularities of long bones associated with platyspondyly of spine. Herewith I am presenting a 5-year-old male child with short stature who was referred to ophthalmology OPD for detailed evaluation. He was the only child of healthy parents with non-consanguineous marriage. He was born out of full-term normal hospital delivery and birth weight was 2.6 kg. History of NICU stay was present for 15 days with history of convulsions, for which treatment was given for 3 years of age. History of delayed milestones was present, but at the age of 5, he was able to ride a bicycle and hop on 2 legs and can also speak 1 to 2 lines continuously. So as we can see in this picture, the child is of short stature. Normally the height in a 5-year-old child is between 103 to 112 centimeter with normal arm span which is equivalent to the height. But in our case, height of the child was 79 centimeter with arm span of 71 centimeter only. The ratio of upper segment to lower segment was in our case 1.3:1. Normal ratio in the neonate or the newborn is between 1.7:1, and at the age of 10 years it is 1:1. But here in our case it was slightly more shortening of the lower extremity was seen and the ratio was 1.3:1. Head circumference was normal, that is 48 centimeter. As we can see, there is frontoparietal bossing is being seen in this picture with scoliosis and protuberant abdomen. Oral cavity was normal and his gait was also normal. Hearing and intelligence were also normal. On ocular examination, there was normal distant and near visual acuity. The child was orthophoric with normal extraocular movements. Hypertelorism was present, and on slit lamp examination, everything was normal except for presence of persistent pupillary membrane. Intraocular pressure was also normal. On dilated fundus examination, few yellowish spots were seen at the macula and few retinal pigment epithelial changes were also seen. OCT was normal and hypoautofluorescence was seen at the fovea on fundus autofluorescence. Radiological evaluation.
Can you sum up? I think you are running.
Yeah. Radiological evaluations in this picture, as we can see, there is presence of platyspondyly, that is widened intervertebral spaces, and there are changes at the metaphyseal ends of the long bones and even of the hands and feet. So on the basis of clinical examination and radiological evaluation, diagnosis of spondylometaphyseal dysplasia Kozlowski type was done. There are different various types of other SMDs are also present depending on clinical presentation and the type of bone involvement and inheritance pattern. The common ocular associations that are seen in SMDs are myopia, corneal dystrophy, then congenital glaucoma, cataract, optic atrophy, pigmentary abnormalities, lattice degeneration and retinal detachment. Although our patient didn't have any significant ocular finding except for the few pigmentary changes at macula with normal color vision, which is an unlikely finding. The diagnosis was done basically by the pediatrician, orthopedician and radiologist. I am presenting this case so as to make awareness about the symptomic features of SMD. Although ocular examination does not help in the diagnosis of this, but surely we can aid to make the diagnosis. It also highlights the importance of thorough ophthalmological examination in all rare systemic inherited disorders, and a multidisciplinary approach is required in the diagnosis and management of such conditions. Thank you.
The speakers are instructed to clearly keep up the timing of 4 minutes per topic. This is a competitive session, so if you overshoot the time, the marking evaluation has to be strictly followed. So next I invite Dr. Nisha.
Good evening everyone. So I'll be presenting the topic as visual, sensory and motor deficits in children with most prevalent developmental disabilities. So top 5 developmental disabilities are Down syndrome, ADHD, cerebral palsy and ASD, and fetal alcohol syndrome. So children with these disabilities have numerous ophthalmological deficits affecting the anatomy of eye as well as the sensory and motor aspects of vision. There has been discussion in literature regarding the association of ocular manifestations and severity of the disabilities in each of these conditions. So in ASD, there is a study found that 40% of children with autism had identifiable ophthalmic issues, most common being refractive errors, strabismus and amblyopia. Many symptoms that characterize the autism, such as odd body posturing, gaze aversion, preference for peripheral vision, and visual stimming, have been suggested to be due to faulty vision. And there's high prevalence of strabismus, around 20%. And in cerebral palsy, children with cerebral palsy have high prevalence of 50 to 90% of visual impairment. Common ocular findings are refractive error, esotropia, exotropia, isolated vertical deviation and nystagmus, and some abnormal dysmorphology also. Accommodation responses are affected in children with CP, with some of reports suggesting a relationship of accommodation with intellectual impairment and communication ability. In ADHD, which is the most common neurodevelopmental, one of the most common neurodevelopmental disorder in childhood, worldwide prevalence of 2.2 to 17.8%. So they have reported have a higher association of convergence insufficiency, reduced stereo acuity, refractive error and accommodation abnormalities. In Down syndrome, it is one of the most common chromosomal conditions in the world, and ophthalmic findings reported in DS include refractive error, amblyopia, strabismus, the NLD obstruction, nystagmus, keratoconus, cataract, retinal abnormalities and optic nerve abnormalities. The most common refractive error in children and adolescents with DS are hyperopia and astigmatism. The association of esotropia and nystagmus in DS is also high, and accommodative lag with reduced amplitudes of accommodation have also been reported. The aim of the study was to study the visual, sensory and motor deficit in these most 4 developmental disabilities, and the objective was to compare these 4 disabilities and see if there are any difference in prevalence of ophthalmic disorders and any differences amongst them. We have included all the children between the age of 6 months to 16 years with these 4 disabilities, and in whom the ophthalmic and orthoptic evaluation and refraction could be done conclusively. We have excluded the children with other neurological disorders with any history of intraocular surgery, or in whom an optimal ophthalmic evaluation could not be done. Study area was the Eye Care Eye Hospital and PG Institute, Noida. Population was all the children with diagnosed with these 4 disabilities, and it was the hospital-based non-randomized prospective study. So we have included 48 patients between the age group of 6 months to 16 years diagnosed with these 4 disabilities, and participants underwent age-appropriate complete ophthalmological examination and orthoptic assessment. So the most prevalent disorder observed among them was the autism spectrum disorder, followed by ADHD, Down syndrome and cerebral palsy. Refractive errors were seen in 37.5% of the cases, with ASD showing the highest percentage, but there was no significant difference was found in prevalence of refractive error and the specific disorders. Myopia was the most common refractive error across all. Strabismus affected 39.6% of individuals, more frequently associated with Down syndrome and cerebral palsy, and esotropia was the most common strabismus type found across all the disorders. And in cerebral palsy cases, esotropia was the only type of strabismus found in our study. Amblyopia was present in 16.7% of total cases, showing significant association with ASD and Down syndrome. Most common type seen was refractive amblyopia amongst all. And some other ocular findings were also found, like CNLDO, nystagmus, conjunctivitis, congenital ptosis, dry eyes and allergic lid edema. And reduced neuropsis is most common sensory deficit found amongst all. So conclusion is that in our study, autism spectrum disorder was the most common developmental disorder. Refractive errors were seen in 37.5%, which was highest in ASD. Esotropia was the most common type of strabismus across all developmental disorders and the only type in cerebral palsy. So all cases with developmental disorders need detailed orthoptic evaluation and early ophthalmological examinations. Thank you.
I have two questions. Sometimes this ADHD and ASD has mixed spectrum, so we cannot clearly demarcate between ADHD and
Yes,
autism.
so we have.
In such cases, how do you do
So we have taken few cases, around 6 or 7, which have both ADHD and autism spectrum, diagnosed by the pediatrician.
when they have mixed features, how do you segregate between ADHD? How did you allot the patients under ADHD?
So we have taken separately both the cases in both the groups. Like one patient with ADHD and autism, we have taken them separately under ADHD and also under the ASD.
Counted them as two patients.
Yes.
Okay. And what if you, when you detect amblyopia in such cases, did you use the same visual acuity estimation test for all the patients?
No, so we
because
have
many might have different level of delayed milestones.
Yeah,
so
yes,
one
so we
test
have
might be giving a not a correct value when you.
Yes, so we have taken the visual acuity according to the age spectrum and as much as
what I'm trying to tell is some test might overestimate the vision. So in that
Yes.
case, you might not be able to clear
Yes, sir.
tell that amblyopia is present
Yes,
or
sir.
not.
Also, in all the patients, were you able to do all the tests? Like, there would be a couple of multiple patients, in fact, where you
Yes,
would
ma'am.
not be able to do a stereopsis, maybe. And
Yes,
some
ma'am.
other evaluations.
Multiple tests were not.
Yeah.
We were not able to perform, like especially in cerebral palsy
What was
patients.
the youngest patient?
Ma'am, 8 months. Thank you.
Okay, thank you. Again, re-emphasizing, please stick on to the timings, 4 minutes, and you might have to reduce your marks even if your presentation is good. So next I invite Dr. Manju Jain Verma. Is he present? He is absent. Dr. Aditya Sharma, please come. Dr. Shahiba Bedi. Dr. Shail Vasavada, can you be ready with the next podium?
So your presentation is on that side.
Just alternate the podiums, please.
Good evening, everyone. I'm Dr. Aditya Sharma, Senior Resident in Department of Ophthalmology, Lady Hardinge Medical College, and I'll be talking about the novel variant in a consanguineous family with ataxia telangiectasia and esotropia. Ataxia telangiectasia is a rare multisystem complex neurodegenerative disorder of autosomal recessive inheritance characterized by cutaneous and neurological manifestation with progressive ataxia and mutation on ATM gene on chromosome 11q22-23. In the following case, I'll be discussing about the various manifestations of the disorder, and the purpose is to study the whole exome sequencing to identify the novel variants in a consanguineous presumptive autosomal recessive family with all three offsprings having ataxia telangiectasia and esotropia. The study is a hospital-based whole exome sequencing analysis of a rare syndrome and whole exome sequencing of phenotypically affected three offsprings, aged 12 years, 16 years, 12 years, and 5 years, with AT and ET, demonstrating different stages of neurodegeneration and ataxia were performed. The children presented with bilateral eye redness, nystagmus, and esotropia. Redness was persistent, no other associated ocular symptoms. All the three children were developmentally normal initially, and they were immunized appropriately for age. Birth history was unremarkable. The children were born of consanguineous marriage, and they had history of repeated episodes of cough, coryza, and pneumonia, but no systemic complaints on presentation. The two older children, that is one male and one female, were healthy at birth, but later on were not able to walk without support and thus dropped out of school. The children were stable and well-oriented. Systemic examination was within normal limits in the younger child, but the older children showed features of neuroregression, difficulty in speech, and ataxia. Head position was normal, nystagmus was present. Neurological examination was unremarkable in the younger child. However, ataxia and gait abnormalities were there in the older children. Visual acuity was fixing and falling. Conjunctiva showed bilateral dilated and tortuous vessels, as we can see in the images. Sclera, cornea, anterior chamber were within normal limits, and so was fundus examination. MRI brain was performed and was found to be within normal limits. Whole exome sequencing was done in all the 3 children, and it identified a homozygous likely pathogenic variant in the ATM gene on chromosome 11q2223 exon 48. Thus, a diagnosis of ataxia telangiectasia was confirmed. The children were prescribed topical decongestant medications, appropriate refractive correction was done, and they were advised exercises for rehabilitation, gait training, and activities to improve trunk balance. Parents were counseled about the type of inheritance, and thus asked to get genetic counseling before planning another child. The incidence of ataxia telangiectasia is more in children born of consanguineous marriages, and usually ataxia is the first noticeable sign in such condition, but in our case telangiectasia was seen first. It is seen mostly on conjunctiva, facial skin, and almost found universally. However, it is more common on sun-exposed areas like ears and face. With progression, dysarthria, oculomotor apraxia also manifest, and this affects vision, reading skills that can impact children during their first years of school. Immunological impairment is also common in around 66% of the cases with low IgA, IgG levels and low CD4 count. Although these children are predisposed to pulmonary infections and tumors of lymphoid origin, fastidious surveillance of breast and ovarian cancer can be life-saving. Cerebellar atrophy is noticeable in adult patients but may be absent in pediatric age group as seen in our case. Antioxidants, antisense, morpholino, oligonucleotide, aminoglycoside, antibiotics that can affect ATM protein are currently being tested for future purposes. Thus, I would like to conclude that the familial concomitant esotropia is a relatively uncommon phenotype associated with familial ataxia telangiectasia, making this a rare case presentation. The homozygous novel variant on the AT gene confirms the autosomal recessive inheritance and supports the genetic counseling to stop further transmission of the condition. Early diagnosis and supportive care are pivotal, and genetic testing is essential for confirmation and family counseling. Thank you.
Okay, thank you.
Can you just put the timer at 4 minutes? It's at 3.5 minutes, the timer.
Absent. Sahiba Bedi is absent.
Yes.
Shahil Vasavada.
Please change the timer to 4 minutes.
Yeah. Very good afternoon. We have no financial interest, and we will be presenting our data on long-term outcomes following congenital cataract surgery performed within the first 6 months of life. And the need for this study is that children less than 6 months of age are very technically difficult to perform, and still less than 6 months of age IOL implantation still remains relatively controversial with higher risks of complication. And although there are data in less than 2 years and less than 1 year, there is no specific data in children less than 6 months of age being operated. So it was a prospective interventional case series done at Raghudeep Eye Hospital, Ahmedabad, India, and infants between 0 to 6 months scheduled for cataract surgery and IOL implantation were taken after proper consent. Associated ocular anomalies like persistent fetal vasculature, uveitis, coloboma, etc. were excluded. Standardized surgical technique of anterior capsular axis, bimanual IA, then posterior capsular axis, along with either in the bag IOL implantation, along with pars plana vitrectomy, or posterior optic capture, only vitrectomy being done only when the vitreous is disturbed. And the final would be in cases where an inappropriate capsular compromise occurs or an appropriate PCCC is not performed, then haptics therapy with ciliary sulcus haptics and captured through the anterior capsular axis. Preferred IOL were either a single piece or a 3-piece hydrophobic acrylic IOL. So 41 eyes of 24 children were included, and the mean age was ranging from 2 to 6 months, and number of unilateral cataracts were 7 out of the 41 eyes that were operated. The mean axial length was 19.5 millimeters, and the horizontal corneal diameter ranged from 9 to 11. 9 eyes were left aphakic due to inadequate intraoperative feeling of an inappropriate cornea size, and 8 out of those 9 patients, 8 out of those 9 eyes had bilateral cataract. One eye which had a unilateral cataract also had to be left aphakic. One eye out of the 41 had an IOL in the ciliary sulcus, or others were implanted in the capsular bag. The mean follow-up ranged from 30 months to 80 months, which means more than 2.5 years to more than 6 years. And visual acuity at the final follow-up, 25 out of 41 eyes could give documentable visual acuity, which had a mean of 0.57 logmar. All eyes had an improvement in their fixation and could follow objects better than what they were before cataract surgery, and the axial length at follow-up did not grow very myopic as can occur in some of those eyes. Coming to the complications, membranectomy and vitrectomy for visual axis obscuration was required in 4.87, that is 5% eyes, that is 2 eyes of 2 patients, both of whom who had bilateral cataracts. And duration between the primary surgery and the membranectomy was ranging from 3 months, 9 to 3 months following cataract surgery. Glaucoma was seen in 12% eyes, and all eyes were controlled with glaucoma medications. None of them required trabeculectomy. And one eye with the sulcus IOL developed inflammatory cells on the IOL in the early postoperative period, which was treated with medical management. So we have shown in our randomized trial that children less than 2 years of age, this was the landmark randomized trial, bilateral aphakia, IOL is safe even in children less than 2 years of age, and recent reports do show encouraging results even in children less than 1 year and 6 months of age. Limitations, of course, being this is a skill dependent procedure, and long term outcomes with a larger sample size will definitely be needed, but you can consider IOL in a case to case basis even in young children. Thank you so much.
The one case which you have placed the IOL in the sulcus, why didn't you go for decide to go against IOL on table rather than going for a ciliary sulcus?
So this was the second eye of the bilateral cataract patient. So one eye already had an IOL, and then the second eye. So therefore we decided that we'd rather have it pseudophakic. Yeah. So in this, so that's what I said, sir, that with the myopic shift, the mean axial length difference was only 1 millimeter, ranging from 3 years, 2.5 years to 6 years follow-up that we had.
Because as compared to the Western literature, Indian eyes, I think, less prone to, I don't know.
Yeah, we also do not see, except for 1 or 2 odd cases which behave very differently, we do not see a very gross myopic shift in most situations, sir. So that's what I said, sir. So 12% eyes. So 5 eyes did require long term. They were on anti-glaucoma medications even at the. So our preferred drug, we start generally with timolol, and only if then other drugs are needed, then we add either brinzolamide. Brimonidine we try and avoid as much as possible. Yeah.
So calling a 3 to 4 years follow-up as long-term would be slightly biased in these patients, since we need. Most of them develop glaucoma, or have this chance of developing glaucoma over a lifetime.
Absolutely,
so,
absolutely. But
yeah, so maybe
the only reason why we reported this is that it's been reported that the younger you operate, the pseudophakic glaucoma is much higher. So just to try and highlight that even in less than 6 months, the incidence isn't as huge as we would like to believe. Yes, ma'am. Yes, ma'am. Exactly.
Have you done? Yeah. Please.
So exactly. So ma'am, we've published our trial on posterior optic capture without vitrectomy, comparing. So we do an anterior capsulorhexis, posterior capsulorhexis. We put a 3-piece IOL, haptics in the back, and we capture the optic through the PCCC. And we received a research grant support from American Society, and we have published our data on randomized trial comparing optic capture without vitrectomy and simple in the bag IOL with vitrectomy. and we found the incidence of all complications including visual axis obscuration to be similar in both groups. So now as our practice, if we are able to achieve a decent size posterior capsular axis surgically, our preference is to do a 3-piece optic capture without anterior vitrectomy.
Have you done peripheral iodectomy in any of these cases, even if you put the lens in the back?
Not ever when we put in the back. So in the eye with ciliary sulcus, we do, yes.
Now, though it is recommended, not needed in the bag IOL implantation, but still when you operate a small children, doing a simple peripheral iodectomy is actually helping the patient not developing glaucoma in the practice. That's what.
Sure, I'm sure.
We have seen, like,
yeah, absolutely.
we do
I'm sure your
routinely peripheral
experience is
iodectomy in
correct.
all the children, even if we keep it in the bag. So our chance, incidence of glaucoma is very rare. And maybe I don't know how it works. I don't know, but it's working practically. So
sure.
At the end of the surgery, just with the vitrector, you can just go and have a small peripheral iodectomy.
Yeah, absolutely.
Thank you. Good presentation.
Thank you.
Dr. Samarth Agarwal. Dr. Suprema Shri. Dr. Karobi Rani, please come. I think that this one. Alternate the podiums.
Excuse me. थोड़ा सा इसका brightness बढ़ा दो. Good evening, chairpersons. I'm going to present my work on early rehabilitation in preterms towards better outcomes. Now, early rehabilitation for preterms is a must, starting in the NICU to avert a lot of issues by providing an environment similar to the mother's womb. Emphasis is not only on early intervention to provide a better quality of life to the neonate. Now, the specifications for early rehab in the NICU includes light levels, sound levels, temperature, and positioning in this degrees. Now, when we have the AAP recommendations for preterms in NICU, the distractions which can be used are toys, illuminated targets, nursery, rhymes, music, mothers singing, and animal sounds. And these recommendations go on right up to 6 months of age, where they can continue even after the child goes out of the NICU in the form of massage, positional exercises, and games, and tummy time. Now, what are the rehabs which can be done in the NICU itself? Warm NICU with dim lights, soothing music, mother's voice, mother's handkerchief next to the baby, mother's smell, mother's biorhythm and her sleep and wake cycles if you give the child to the mother once in a way, neonatal cuddler, oromotor stimulation which includes sucking, rooting and snout reflexes, swaddling and kangaroo care, therapist assisted range of motion exercises, neonatal aquatic physiotherapy which comes little later, kinesthetic stimulation with exercises little later, and reduced pain stimuli because the pain insults are more in the younger age group because they are pricked very often, the eyes are seen, etc. Early rehab after that at 6 months starts with the visual the eyes are definitely seen earlier up to 3 months, but at 6 months you have to do their cycloplegic refraction, glasses, vision therapy, amblyopathy therapy if there is, and squint correction if it develops. So later interventions are those of oral motor interventions, occupational therapy, physical therapy, speech and language therapy. The comparison between two sets of preemies from 2 hospitals, we waited for at least about 6 or 7 years to collect the same kind of children. That is, one is a state-of-art multi-speciality hospital with all amenities in the NICU with expert physiotherapists who come and give the therapy, and 15 preemies ranging from 26 to 32 weeks gestation, birth weight ranging from 800 to 1050 grams. So we have kept those things static, and the amount of oxygen given was blended oxygen over 2 to 5 days in the hospital X, which was the good hospital, as against another hospital labeled Y with no such amenities. We found that the preponderance of males was more in the good hospital, and in hospital Y it was almost equal. The gestational age ranged between 29 to 30 weeks in the X group, and in the Y group it was 26 to 28.6, which had major prevalence of cases. And the birth weight ranged from 800 to 900 in the hospital X, and the hospital Y showed 800 to 900. The risk factors that we studied were in this way. The hospital X showed apnea, bradycardia, aspiration, hypoxia, feeding much lesser than hospital Y. When we talk about early rehabilitation in terms of eyes, we found that number of patients who developed ROP was 26.6, and treatable ROP was 13.3, as against 33.3 in the other group. Motor, speech, cognition, behavior, dental was more in the hospital Y. The ADD, ADHD, CP and ASD was more in the hospital Y. And the number of glasses is almost similar, between 80% and 86.66%. So the inference is hospital X preemies were overall better than hospital Y, where early rehabilitation was carried out. The need for glasses was the same in both groups. Thank you.
Okay, so ma'am, since you were saying that there were motor, speech and cognitive functions were better developed when they were in hospital X, at what age were they finally evaluated for this?
See, generally you evaluate them around 2 or 3 months, because if the child is showing any kind of signs of vision, of course they will not respond, but the motion exercises also help. And then as the child goes up to 6 months of age, you can have a definitive idea.
But speech and cognition would also not be as easy to evaluate.
It wouldn't, but this is a follow-up, as I said, is of over 6-7 years. So we have followed these children right up to that point. So we are able to see, because they are referred early, whoever has a problem, to the physiotherapist or the occupational therapist, later to the vision therapist, to whatever is needed for the child, and then accordingly they get their rehabilitations. But we found that where they were given early rehab, they fared much better than the subset which didn't have the early
So the rehab that was given after they were out of the NICU?
No, it's starting in the NICU.
Starting in the NICU,
Yes.
but after that they
Even
would have
after
been
that, yes, it
continued on
continued.
some kind of a special education or a vision therapy, and on
It
all other
continued.
kinds
As
of
I said,
rehabs.
that this was in the NICU, that was the early rehabilitation. Then it went on even when the child had gone out of the NICU.
Yes.
It went on at 6 months, where we come in, and the vision therapist, if there is a requirement, comes in.
So-
and then the oromotor and all the occupational and physiotherapy continues thereafter if there is a problem.
So
faced.
this rehabilitation that was done after the NICU was the same for all the children? It was the same facility?
Whatever
or
was the
that could have-
requirement.
But it was done at the same place and by the same people?
Yes, it was done by the same.
Because that could be a changing factor. If some children did go for further rehab and some did not, or they went to a different center where the rehab facility later on was not as great, then that would also affect the
No,
results.
it was 2 hospitals in the same area, referred to the same people who are in that vicinity.
Was there any confounding factor like birth weight, gestational age, that may be the reason for this difference in between the hospitals?
That's the reason why we have taken the same
taken the same,
birth weight. We've taken the same gestational age. So
Okay.
we didn't want discrepancies on that. So we have taken this, and we found the results to be like this. you know.
Okay.
Thank you.
Thank you. Dr. Vaishali? Dr. Vaishali, is she present? Please, this podium.
Good evening, respected judges and co-presenters. I guess we are the only presenters who are in the hall. So, it's a part of, I'm presenting a part of the study of the largest study group. It's about the clinical profile of study of strabismus patients. So strabismus is associated with amblyopia and adding another spectrum to the functional disability, and the prevalence is around 0.5 to 5%. So the main goal of treatment in strabismus is a restoration of eye alignment together with fusion and stereo acuity. So this was carried in the tertiary care referral hospital at the Government Medical College, Aurangabad, previously known, now it's Chhatrapati Sambhaji Nagar. So ethical clearance and a detailed history, birth, family history was taken, and visual acuity assessment, cycloplegic refraction, anterior segment examination and fundoscopy was done. So coming immediately to the results, out of the 720 patients, we had our almost 18% had strabismus, and in the 18% we had 55 cases of males and 74 were females. And history of consanguinity is another major issue in our region, and that was almost 34% were born out of consanguineous marriage. So there's another study regarding this. The premature cases which ma'am just highlighted were 4%, and NICU admissions were 15%, and amblyopia was diagnosed in 30%. 10 cases had a history, a family history of strabismus. So we found that excuse me, esotropia is most common, which is of intermittent exotropia. Stereopsis was seen in 91% of intermittent exotropia cases, so we didn't have to go ahead with the surgery, and 30% of the esotropic patients had accommodative esotropia. So total 14 patients were operated during this period. For exotropia were 8 and 5 for one who had esotropia with hypermetropia. So this is about exotropia and esotropia. And intermittent exotropia were 36, whereas constant were 15 cases and sensory were 7 cases, whereas those with convergence insufficiency were 5. Whereas in accommodative esotropia were 18 cases, partially were 25, and infantile were 13 cases, and sensory esotropia there were 4 cases. So it is a multifactorial influential trait and shows wide variations, and the geographical regions of the world had where sunlight was high had exotropia as the commonest form. We also found that the hyperopia to be most common in our study population, along with a few incidents of myopia as well. So being a single center study, our study has limitations, but we are trying to substantiate it and give the management accordingly. So these are my references, and thank you for your patient ear.
18% of squint in a population appears to be very large, I think. And this 720 patients are walk-in patients in your hospital,
yes,
or did you reach to any community?
No. All coming to the OPD.
So then means if you go to the community also, then the percentage might be bigger picture than what it is projected.
Maybe because my OPD days are fixed, so they know that this is where pediatric ophthalm and squint clinic. So
many might not come.
Yeah.
I mean, thinking that squinting is not a very major issue. Something
But
like
that 18% is of the patients who are attending the OPD.
OPD.
It's
Okay.
not,
not the population.
Not of the population.
Okay.
Yeah.
Doesn't reflect the overall incidence.
Overall prevalence, no. Just those who came to us.
Okay.
Yes.
So ma'am, you said 91% with intermittent XT, and you did not operate them just because they had stereopsis?
No,
we still need to operate if the angle is large and the Newcastle scoring can be done or anything like that.
But the paper published by Pradeep Sharma sir says that those who have good stereopsis, so we can give a trial like the exercises, pencil push-ups and the conversion. So we gave a trial for that. Yes. Yes.
Even if
usually stereopsis is the criteria. If they have good stereopsis, so
So a very large angle intermittent exotropia
No, of
with
course.
a 90 PD will and if the control is there, we'll still have stereopsis, but we still need to go ahead.
Yes,
and
yes,
do
of course. I mean, that
And
was a broad
stereopsis,
statement.
I
That's
think
true.
most of the stereopsis which normally the textbook says is the distant stereopsis, but
Yes.
unfortunately we don't have any
Don't, yes.
instruments to measure that. So when you look into only stereopsis point of view, near stereopsis is the last one to go.
Correct.
So maybe now I think maybe we might have to be aggressive in operating in that age group.
I agree. I don't have the distant
It is
stereopsis.
available, still it is not widely available across all the
widely
centers.
available.
Yeah.
Thank you, ma'am.
Thank you,
Thank
madam.
you
Yeah,
so much.
Dr. Swarnima, please come. Yes. The slides are visible. Yes, you can start.
Good evening, everyone.
I think you can tell the mic a little bit. Yeah.
Good evening, everyone. I'm Dr. Swarnima Jain, second year DNP resident in Shankar Nethralaya, Chennai. I'm here with a case on every strabismologist's nightmare, the oculocardiac reflex. Today, we aim to report a case of unforeseen asystole during strabismus resurgery and to highlight the possibility of extreme oculocardiac reflex during resurgery, even if there was no such event during the first surgery. OCR is a trigeminovagal reflex response to pressure or stretch receptor elicited stimulation of orbital contents, especially extraocular muscle traction. A reduction in the heart rate by more than 20% with decrease in myocardial contractility via vagal response is seen. The incidence is more with cyclovertical muscles and least with lateral rectus muscle. Coming on to the case, we have a 22-year-old female who presented with recurrence in outward deviation of the left eye 5 years after squint correction. She had undergone left eye lateral rectus resection and medial rectus resection with anterior transposition of inferior oblique under general anesthesia without any complications. On examination, there was no head turn and face tilt. A Hirschberg's test showed 45-degree left exotropia. On prisma cover test, 45 prism diopter of exotropia for distance in ear was seen, with 6 prism diopter of dissociated vertical deviation in the left eye, and a V pattern exotropia suggestive of inferior oblique overaction was noted. Worth 4 dot test showed left suppression, and stereopsis was reduced as tested by the Titmus fly method. The best corrected visual acuity was logMAR 0 for both eyes, and the extraocular movements were full, free, and painless in both eyes. The intraocular pressure, anterior and posterior segment, was within normal limits in both eyes. We came to a diagnosis of left eye recurrent V pattern exotropia and decided to manage it by a surgery where both eyes inferior oblique recession was to be done, with the right eye lateral rectus recession with medial rectus resection under general anesthesia. Intraoperatively, the pre-medication was administered 45 minutes pre-op with anticholinergics, and induction of anesthesia was done. Maintenance of anesthesia was done using oxygen nitrous oxide and sevoflurane, and the surgery was commenced with vitals within normal limits. 30 minutes later, when the left eye inferior oblique was isolated and hooked using Stevens hook with minimal tension, an extreme OCR was noted where within few seconds the heart rate dropped to 0. The muscle hook was released immediately, and intravenous bolus of 0.6 mg atropine was given, and the cardiac rhythm was restored with a heart rate of 100 to 110 per minute. The surgery was resumed under cautious systemic monitoring and minimal extraocular muscle traction. No oculocardiac reflex was noted while dealing with any other extraocular muscles during the surgery, and the surgery was completed. Reversal of anesthesia was done by giving intravenous anticholinergics, neostigmine and glycopyrrolate, and the postoperative period was uneventful. So here we are to discuss the oculocardiac reflex, which can be influenced by age and is seen more commonly in children. The depth of anesthesia also affects the oculocardiac reflex, and it is less in superficial anesthesia. Anticholinergics are helpful in tackling bradycardia. However, there is a risk of ventricular arrhythmias with prophylaxis. Sevoflurane and desflurane are considered to be safer pre-medications. Retrobulbar anesthesia is a safer option than general anesthesia, and the duration and amount of fraction on the EOM also has an influence on the oculocardiac reflex, where more prolonged and higher tension pulse can be associated with a rebound tachycardia. A prospective trial study showed significant rise in the rate of profound oculocardiac reflex during one or more resurgeries if the same had occurred in the initial surgery. But our case showed no records of oculocardiac reflex in the initial surgery. So we can manage the oculocardiac reflex, however, but if the drop in the heart rate is less than 20%, we need no treatment. And if it is more than 20%, and if it's a profound oculocardiac reflex with 50% increase, we have to manage, but we also have to restart the surgery. So the take-home message is that every case, including a reoperation, should be dealt with an intraoperative vigilant approach. There should be conscious monitoring of the vitals at every step and appropriate control over the pressure applied on the ears. Thank you.
Yes.
Sorry, sir? No, sir.
Yeah, because it's a protocol in our center. If it's a small baby, even after general anesthesia, you need to give the peripheral block, especially for schools.
We don't follow that. We don't follow.
Because in fact we had conducted one study, of course, which was by anesthetist. The incidence of oculocardiac reflex is much more common than what we think, because it was I think anesthetist, one of the thesis topic was there. But the incidence of oculocardiac reflex is much more. Of course, we don't realize it because they are monitoring them.
Just by using glycopyrrolate preoperatively, when inducing the patient with general anesthesia, the rate of OCR goes down.
Blocking the afferent link, number one. The incidence of post-operative nausea vomiting is less. The amount of anesthetic gases required for maintenance is also less, and post-operative analgesia is good. So that's why it's our protocol. Even after giving general anesthesia, always give.
Yeah, there's nothing wrong, but I mean, it is not generally followed in most of the institute. At least in whatever institute I know, it's not followed.
But we routinely give glycopyrrolate for induction.
We don't give a block after G. That is very important. Yes, nausea vomiting is much less when we block the patient. And there is nothing like if the patient has not had experienced bradycardia in the previous operation, doesn't mean that he shouldn't experience in the other eye or next reoperation. So each surgery is taken differently. So it's basically, as you mentioned, because of the stretching of and prolonged stretching of the muscles. So I mean, any surgery, even if it is resurgery or you are operating first, you have to be aware of the oculocardiac reflex. The other important thing, as strabismus surgeons will agree, that in addition to the removing the speculum immediately after you notice the oculocardiac reflex, sometimes it is better to remove the lid speculum also. In addition to the muscle hook. So any stretching to the eye has to be avoided when the patient experiences oculocardiac reflex. This is very clearly, I think it's given in Rosenbaum also. And most likely this is happening because of the assistance. So the surgeon who will be more concentrating in the suturing, young postgraduate or a fellow or assisting sisters, they might keep on stretching the muscles. So you might have to give clear instruction to the assistant when to hold it whenever you need it for suturing, and when you're not doing any manipulation, you can just relax the muscle rather than keeping it pulled always.
And you have to tell the person who's assisting that keep your eyes on the ears of the monitor.
Exactly.
Anesthetist. That is what
many times the surgeons has to see the monitor, because sometimes when you keep operating, you will not see the monitor at all. So I keep telling my fellows that monitor has to be direct in contact with the surgeon's eyes. So
just a basic protocol that whenever you're hooking the muscle, you just say it out loud for the anesthetist to know that you're hooking the muscle. So if there is anything, the anesthetist always has his eyes on the monitors.
Exactly. Good presentation. Thank you. So I thank all the speakers for a wonderful presentation, and then we'll take on group photograph with all the presenters, please. Which hospital are you in?
Sir, I'm in base hospital, the Armed Forces Medical Center.
Okay. Nice. Oh, thank you.